webinar. We are just waiting a few minutes for more people to join, and we will get started. Thank you.
Good morning, good afternoon, good evening. My name is Wafa El Sadr, and I'm the Global Director for ICAP at Columbia University. I want to welcome you all today to this very important special webinar entitled Addressing Violence in the Wake of the COVID-19 Pandemic. This is an alarming issue that the global community is facing at the present moment. I want to thank all the speakers as well as all the panelists who have joined us today to share some of their work and experiences on this important topic. I want to also introduce and welcome Dr. Andrea Lowe, who was instrumental in organizing this webinar. Dr. Lowe is a physician and epidemiologist at ICAP at Columbia University. She has led and is leading several surveys that have been conducted that are focused on a variety of different populations, some general population surveys, as well as also VACS surveys. She is also an assistant professor in the Department of Epidemiology at the Columbia Mailman School of Public Health. Welcome, Andrea.
Thank you, Wafa. And thank you to our panelists, our speakers, and to our audience for joining this really important discussion. I think what can only be described as a really uncertain time for people. So next slide. Today, I'm just going to be briefly discussing some of the history of ICAP's work with violence prevention and understanding the burden of violence across multiple different countries and settings. So as the HIV epidemic evolved in the 1990s and early 2000s, a lot of evidence came out to support the fact that sexual and gender-based violence was a risk factor for acquisition of HIV in women, transmission of HIV within communities, and that it could also contribute to poor treatment outcomes. Those people who are victims of violence often would access care late, or they would be lost to follow-up, or they would have poor adherence to their medications, and would often present with advanced immunosuppression. So recognizing that, back in 2007, the government of Rwanda and ICAP worked on a project to develop national guidelines for a response to sexual and gender-based violence. And this was PEPFAR-supported due to the links between this violence and HIV. As part of this, ICAP and the government of Rwanda developed clinical training and tools. This included training people at multiple different levels of the health system and training some people as mentors to providing ongoing training for people as as people access services. It also involved developing a monitoring and evaluation framework and developing a more robust system of referral of victims of violence to legal and other services. As you can see here on this side, it really required the engagement of people at multiple levels of the government as well. So here in the top picture on the right, we have the police, we have the army, and we have other leaders from the community. And the Humura One-Stop Center was a place where people could easily access a number of different types of services for when they experience violence. And next slide, please. So based on this experience, ICAP has then been able to expand into a number of different countries where they work with governments and other national stakeholders to implement programs. And this is often part of HIV site support. You can see here a few countries where we have data dating back to last year: Cote d'Ivoire, DRC, Eswatini, and Ethiopia. Certainly the middle three, they predominantly provide sexual violence care, and that's a big focus on post-rape care and providing things like post-exposure prophylaxis as well as psychosocial support. And in Kenya and Mozambique, they actually expanded that to also provide physical and or emotional violence care. As well as in Cote d'Ivoire. And we have someone from Kenya who can speak a little bit more to some of the programs there, Mark Mayo, a little bit further on. Next slide, please. They also really focused a lot of their efforts to respond to what were found to be gaps in the services in the community. So in DRC, the government and other stakeholders really felt that community health workers would be an ideal target for training and who could provide support for people within their communities that they served. And this is based on an abstract by Dane et al. From the AIDS conference in 2018. And you can see here, a lot of training was done for community health workers to go into communities and do screening at both the individual and group level, and to identify pediatric and adolescent cases that are famously really difficult to find. And you can see here that this would involve them actually escorting people who said that they'd suffered from violence. They'd actually escort them to services, to healthcare referrals, and provide stepwise support for really vulnerable people. And you can see some of the results here. As I mentioned, that this group is hard to identify, and you can see some of the successes that were had in terms of really bringing young children and adolescents into really life-saving services. Next slide, please. So on top of some of the service provision that ICAP has been involved in developing, we also have data collection. So ICAP has implemented several of these bio-behavioural surveys across Central Asia and Sub-Saharan Africa, as well as recently in Myanmar. And these surveys all include a module that captures data on experiences of abuse and different types of violence. Next slide. Here we can see some of the results from this. Dr. Loherta and her colleagues published this based on a survey that was done in Mali of men who have sex with men. And you can see some of the violence that was captured. So here, 15% of MSM reported having experienced forced sex, and data was captured on the perpetrator here. And many men also reported having suffered harassment or abuse because of their sexuality. Here, almost 1 in 4. So these surveys really target not just men who have sex with men, but other people who are at risk of HIV acquisition. So depending on the context, we've done surveys with female sex workers, transgender people, truckers, people who inject drugs, and so on. So next slide. Some of the other surveys that we've been working on, and on which here I'm the clinical and scientific director on the PHIA projects. These are the population-based HIV impact assessment surveys, and we've completed these now in 15 countries. We are about to restart data collection in Uganda and Haiti. Uganda, it's the second round. We had to hold on some of our surveys because of COVID, but we've found ways to respond to it. We've actually been able to do second rounds and complete them in Zimbabwe and Lesotho. And all in all, we've done interviews in close to 500,000 people across these countries and tested adults and children in over 400,000 people. So this enormous amount of data has been collected. As part of these surveys, we also collect data on viral load suppression, on recent infection that enables us to generate estimates of incidence, and these involved questionnaires as well, where we collect data on demographics and risk factors and access to care and so on. Next slide. So as part of these, we've actually included in several countries some of the violence questions that you find in the Violence Against Children surveys that I'll be discussing shortly, and Dr. Massetti from CDC will be discussing a little bit more at length further on. The countries would determine who they wanted to include, and so it could include girls as young as 10 and no upper age limit. In one country, Uganda, it was restricted to young people, but here it was young women and men. In most of the surveys, they did include sexual violence questions. So these include pressured sex and forced sex. And in some countries, they also included questions about physical violence as well. I think, interestingly, we've also included gender norm questions, which for the most part are looking at gender equity, but in some countries, here in bold, we also collected data on norms around violence within households. So very valuable data. Next slide. And I apologize for the dog in the background. But if you look at this side, this is done by a student this summer, Sachi Inoue, where she collected the data and she looked at the distribution of age at the first incident of physical violence and of sexual violence among among women in Zambia in 2017 and 2016. And you can see here that the distribution of ages at first, physical violence is much broader than it is for sexual violence. And sexual violence really occurs, the first incident, in younger women, particularly before the age of 20. So adolescents seem particularly at risk of this. Next slide. She also pulled out where people were able to seek help for violence. And you can see that the vast majority for both physical and sexual violence did not seek help from anyone. But then you can see the distribution of where they would seek help. And in most cases, it's either other, which is sort of a grab bag of different places, but you do see that police or security personnel were involved in some of these cases. Next slide, please. So this brings us to the Violence Against Children surveys. These are led by CDC. They're PEPFAR-funded. They work with the Together for Girls partnership. They have done these surveys all across the world. They're surveys targeting 13 to 24-year-old young people who report both recent and historical episodes of emotional, physical, and sexual violence. Similar to the VACS, we would also ask questions about perpetrators, seeking of help. We can tie them quite often to health outcomes. So in many countries, HIV testing is part of these surveys. We see how these link to other health conditions and risk-taking, testing behaviors, and then analyses are done looking at risk factors for violence. Next slide. So the Violence Against Children and Youth Survey in Lesotho, the final report has just been launched. Here's the cover on the right. If you're interested in these or any of the other surveys, you can access both the final reports and you can request access to the raw data on the Together for Girls website. You can see here that sexual violence was relatively common, particularly in girls at 15% who had suffered sexual violence, and physical violence, 1 in 3 girls, and almost 60% of boys had suffered from physical violence. And the questions aren't just sort of a spank, but these are pretty severe episodes of violence. For those girls who'd had sex before the age of 18, almost 1 in 5 reported that it was physically forced or coerced. And although not most girls, but almost 50% of girls who'd experienced sexual violence would at least tell someone, only 9% actually finally received services. So identifying some really key gaps and really providing some important data on policy that needs to improve these outcomes. I think what I find striking, aside from these high levels of violence that you see, is that we can also tie it into the fact that those children, those people who reported that they'd experienced violence in childhood, were consistently associated with also being perpetrators of violence. And this was both in girls and boys. So next slide. Some of our work now in terms of violence prevention and COVID-19 surveillance projects. ICAP right now is involved in a number of surveillance projects in many different settings. In most settings, we're not actually focused on the violence components, but we've been able to include them in a few of our surveys. So Solutions for Sustainability is a project in Mozambique. It's a collaboration with the Earth Institute, with INS in Mozambique, the Meteorological Institute there, and a number of other stakeholders, where we are, originally it was designed to look at the health system response to the cyclones that occurred there in 2019. But aside from the fact that many of our interviews and so on got put on hold because of the COVID pandemic, recognizing that natural disasters have some of the similar impacts on the health system and on people being able to access care as a pandemic does. We've expanded the protocol to include other objectives to relate to COVID-19. And we're looking also at experiences of violence and whether there are increases observed both from cyclones and from COVID-19. We have a funded project from the New York City Community Trust where we are looking at older residents of New York City, people who are already very vulnerable to morbidity and mortality from COVID, who are also suffering a lot from isolation and possible financial and mental health detrimental impacts from the pandemic. And in these, we are going to be capturing increases in verbal and physical abuse. And we do hope to do a knowledge and attitudes and practices survey of LGBTQ populations in New York and determine also their experiences of intimate and general violence. Finally, next slide. Sorry. We will be talking a lot about the associations between various factors linked to COVID and to violence and what might be driving associations, aside from the response. But one thing that I always find very sobering is some of the patterns that we've observed in our PHIA data, in particular between food insecurity and intimate partner violence and other forms of violence in communities. And this is from the World Food Program from yesterday, looking at prevalence of insufficient food consumption. You can see that there are really high rates in many countries in sub-Saharan Africa, in the Middle East in particular, and also, but throughout the world, you're seeing areas where they have very high prevalence of insufficient food consumption, with almost 1 billion people with insufficient food at this moment. So something I think we need to consider moving forward while we think about the response. And that brings me to the final slide. Next slide. So I just want to thank you for this. If you do have any questions, please put them into the chat box. We have time at the end of this session to hopefully respond to as many as possible. But at this point, I wanted to pass over to Dr. Diop from UNFPA, who will be presenting the UNFPA prevention and response to violence during COVID-19. So Dr. Diop is she has a PhD in demography from the University of Montreal and a master's in socioeconomics of development from École des Hautes Études en Sciences Sociales in Paris, as well as a master in sociology from the University of Nanterre. She's the chief of gender and human rights branch in the technical division of UNFPA and has more than 20 years of experience advocating for sexual and reproductive health, human rights, and gender equality. She's been implementing complex programs and establishing multiple partnerships and demonstrating leadership and technical support globally, especially to African countries and the Middle East. She has been, Dr. Diop has led to programs to change entrenched social norms and harmful practices accessibility to adolescent sexual and reproductive rights services, family planning, maternal health, STIs, HIV/AIDS, and post-abortion care. So welcome, Dr. Diop. I'm delighted that you can speak to us today.
Thank you so much. Thank you for having me. So I will try very quickly to present you what UNFPA is doing, you know, sometimes in partnership with other UN agencies and sometimes, you know, alone. So I have a lot of slides, so I will try to go very quickly. Next. I would like to start by saying that the socio-economic impact of COVID-19, you know, has been really, you know, seriously mobilizing the whole UN agencies around the Secretary General report. And there are some key messages there on particularly regarding violence, which are of course calling for more increased investment for a better criminal and judicial systems that need to continue to prosecute abusers, for emergency warning systems in pharmacies and grocery, shelters as essential services, safe space for women to seek support, avoid releasing prisoners convicted of violence against women in any form, and scale up public awareness campaign, etc., particularly targeting men and boys. Next. So this agenda has been also now culminated to a big effort that is called the GBV political strategy by the United Nations. And it has been approved, you know, a month ago. And currently we are starting rolling out that political strategy because we do think that there is a lot going on, but a lot of scattered activities here and there. And the idea is really, you know, the goal to elevate a little bit the whole discussion. So I just want to say that during the COVID, of course, pandemic, as a response to it, there have been a lot of global initiative to, you know, re-engineering and retailoring programs and advocating, of course, for, you know, more effort and more attention to violence, you know, as one of the impact of the pandemic. We have seen a very strong response from donors who are really leading by examples. I mean, so those are few examples, but you know, the different appeal, humanitarian appeal that has been, you know, organized and launched, you know, MPTF call for proposal, etc. All those, you know, with a very strong response also from the donor community. And of course, the UN as, you know, agencies, you know, came together to issue a lot of different documents, joint, you know, interagency initiative, you know, policy brief, statement, etc., really to continue to encourage, raise awareness, but particularly encourage government to act more rigorously during the response to the pandemic. Next. UNFPA particular intervention are really, you know, looking at what we call the 6 points of the Secretary General agenda, and particularly focusing on supporting services to continue the duty of care during the COVID pandemic. Also, you know, ensuring that research and data are collected, but in an ethical and safety standards way. Next. What UNFPA did very early in April was to try to put some scenario and behind, you know, the violence, because we already knew, of course, for a long time that when there is humanitarian crisis, Ebola or a lot of other pandemic and all, one of the main major reaction is that we are seeing the increase of violence, and particularly intimate partner violence. But the point was that in this case of the pandemic of the COVID, we're seeing something that we have never seen in, before, which was a lockdown. And lockdown in most countries, interruption of schools, interruption of a lot of protective mechanism. And so we, very quickly work with different academia partner to be able to put some scenario behind that. And by only taking the 20% increase, scenario, we were seeing that actually the pandemic will negatively impact ending gender-based violence by 2030, which is our goal. And as you know, UNFPA has signed up for several, since last year, and the ICPD at 25 anniversary for the zero GBV by 2030. So we have seen that the impact will negatively affect the zero that we are looking for by 33%. So that was a big wake-up call for the whole institutions. Next. And in terms of course, the response, all the country offices where UNFPA has a presence, and we are talking about 150 countries around the world, started to really look at more carefully what was the programming in the gender-based violence and how they could really respond to this COVID-19 context and increase the efforts by strengthening systems, by adapting to the capacity of the staff, government and partners to deliver GBV services in line with global guidance, but within this COVID-19 context, by continued advocacy for the necessity of services and policy as a priority into the preparedness and response to COVID-19, by looking and providing guidance on collecting data ethically and safely. And maybe you have seen, for example, the decision tree that has been released recently by the UN agency regarding the ethical and safety of data collection, during this kind of pandemic, capturing knowledge and documenting, strengthening coordination and collaboration, which is really key, not only within the UN systems, but also, regarding mental health, psychosocial support working group, etc. Next. Now, maybe to break down, a little bit what each of those response. Next. For the prevention and the risk mitigation, for example, I'm just going to give some example of things that we have done and are still doing. One was engagement of armed actors. And as you know, when they were in the lockdown, the only people who were outside was the army and the police. So that was a very interesting entry point. Police, used to be a partner, but the army, less, in less partnership with us. So that was quite interesting to really, strengthen, the capacity to really prevent, outcomes for women and girls. Continue and use community-based radio and all these other mechanism, TV, SMS, social media, and all to integrate, this COVID-19, but the GBV, impact of the COVID-19. So some of the agency call about the pandemic, was it the pandemic, the shadow pandemic, etc. So that was really, requested, a big effort to bring the attention of government, civil society organization, people, women, girls, etc. Having, emergency distribution a card to communities that can provide, where the services are available, where you can, refer, for psychosocial support, etc. So a lot of different things. And one of the biggest efforts was to include in national contingency preparedness and response plan, the GBV, essential services, as part of the COVID-19 response. And of course, engaging all the different actors, faith-based, etc., women's youth. Next. In terms of services, what we did is, look at really the adaptation of dignity kits. If you know what UNFPA is doing in humanitarian context, is those dignity kits that are being used, to support, women and girls, who are facing those challenges. And those dignity kits are culturally sensitive, created. And it responds, of course, to a local context usually. So that adaptation needs to integrate the COVID-19 context, the PPE, all the protection equipment, etc. And of course, making sure that the GBV, response and system, will be also known to women and girls. We also work really hard in making sure that, the knowledge will move from country to country. And it was really difficult at the beginning of the pandemic to see that everybody was looking at what we should do. What can I learn? Where should I act? What is the best entry point and all? People were really panicking within our country offices and with their partners on, to find, how and what could be the best response with something that was really not, expected. Political trouble are usually expected and controlled, and there is, part of our work, the environment scanning of the political, terrorist, etc. situation. So that one, and the preparedness is done for that. But in this case, it was really unexpected to have that kind of pandemic. And so it was important to put very quickly in place a knowledge sharing, on strategies and promising practices without knowing if it will work or not, but at least, sharing what people were doing here and there. Next. In terms of life essential services also and the response, of course, you have seen the shelters, and those shelters are one of the big investments that UNFPA and other partners are doing. So it was important to create new shelters because most of the shelters actually very quickly were filled and couldn't accommodate more people. I can give an example of a country like in Ethiopia, where we had, about 30 women who were staying in the police station because there were no shelter available and place in shelter for them. So these poor women with the kids, of course, because they left the house with the children, were in the compound of the police, and you can imagine the conditions there. So there were a need to think about, how to increase the number of shelters where women can find, a space, a safe and safety. We also look at how to provide, remote case management because nobody can move in that condition. So it was important to look at remote way of accessing, remote legal service, remote judicial service, remote, counseling services and all. So those are things that, the countries try here and there. Next. In terms of, those one-stop crisis center, it was also very important to ensure that the health sector response, will stay stronger. And as you know, that was also one of the threats. That's not only the shelters, but also, the health system as a whole, including, all the service for contraception, HIV and other maternal health will be disrupted. So it was, a whole holistic type of effort to ensure that the sector response and the health sector response will also respond to and refer GBV cases, which is what is recommended in the essential service package that has been, implemented for a few years now, almost 3 years. But as you know, not all the countries and governments, have endorsed it as an essential service package. So there were a lot of anxiety regarding that, and more advocacy and effort to really accept the essential service package as a key component of the national response to COVID-19 and to GBV pandemic. Next. I'm almost done. I will just talk about quickly capacity development. I already touched a little bit on those, but a lot of virtual trainings had been put in place, and online trainings for police hotlines workers and frontline health workers, on also not only providing support, but also taking care of their own, mental health, resource kits, guidelines for service providers, etc. Next. And I think that the last one is really in terms of research and data collection. Next. What we have done is, of course, guidance note on GBV data collection, and I think that I mentioned the tree. I don't have it here in the picture, but the decision tree is quite important and has been issued with WHO, UN Women, different UN agencies, because the last thing that we wanted was people and partners running everywhere to collect data from survivors, on gender-based violence and all. And we wanted really to protect, also the women and the safety of the women and all. So even, this online and telephone research, mechanism and all could, put the women in danger. So we were not supporting that. And we very quickly issue, different tools to ensure that this is not going to and people will wait really before collecting those data. But what we did is, of course, the technical support to national socioeconomic impact assessment, and those impact assessments were done in all the countries, and it was important to ensure that GBV will be part of that impact assessment. That the gender analysis will be done, and that the GBV service provision and all will be also assessed through rapid assessment. Next. Yeah, I just want to flag few challenges, which is, of course, the difficulty of engaging the health sector, because as I said, it was only 2 or 3 years ago that the essential service package has been launched, the framework, and so the capacity development were going on, etc. So it was not, we were not yet there in some countries, even if countries, responded, positively to the essential service package as essential to the health response and all. So now we had to move into the COVID-19 response in all these situations and ensure that the health sector will respond. And of course, as you imagine, with all the difficulty of people who were completely overwhelmed themselves, the lack of understanding of gender transformative and gender just response, under-resourced and overwhelmed service providers, GBV response workforce due to COVID-19 impact at home and at work settings, and how we can really address that, because one of the immediate impact was a decrease on, the calls, for example, the hotline calls. But it wasn't. That doesn't mean that that was a decrease in gender-based violence. No, there was a decrease on the call because of probably the condition were not, sufficient for the women to, to call, etc. So this is why also, some of the strategies through the pharmacy and all was quite interesting. we also saw during this COVID-19 an increase of a new form of violence and new means of perpetrating violence. And of course, this restriction, coinciding with a potential, dismantling of GBV, remote services and all. So it was a lot of challenges that we are still facing. But what I can say is that in terms of, people are just adjusting as they are going within this experience, which is new. I didn't even touch the issue of child marriage, FGM, which we know has increased and was reported everywhere because of the school closure and all, and the poverty, and the fact that married, your daughter could be a survival strategy. So I didn't touch on those one, but we're still facing that very, very challenging moment in responding to this pandemic and the bigger gender-based violence, including female genital mutilation, child marriage, response. Next, and I think that was the last one that I wanted to let you with, the Secretary General, quote that COVID-19 pandemic is a public health emergency, an economic crisis, a social crisis, and a human crisis that is fast becoming a human rights crisis. Thank you. Over.
Thank you so much, Dr. Diop. And we have some really interesting questions coming up in the Q&A chat box, which I hope we'll have time to answer at the end of the session. So let me move on now to Dr. Catherine Staten. This will be a discussion more about the domestic response to COVID-19 and violence. So Dr. Catherine Staten is the director of the Injury and Violence Prevention Program at the New York City Department of Health and Mental Hygiene. She oversees the epidemiological study of injuries and violence and guides data into action through monitoring fatal and non-fatal injury and violence in New York City over time and place, identifying populations at risk, disseminating data, and providing technical assistance on prevention policies and programming. This includes a broad range of topics, including intimate partner violence, motor vehicle related injuries, and suicide and self-inflicted injuries, as well as child injuries. Master's and a PhD in clinical psychology from SUNY Stony Brook. So welcome, Dr. Musetti. We also have Mea Mantoa Sejaki, who's the Acting Child Protection Director for the Lesotho Ministry of Social Development. Trained as a social worker, she has been working for over 20 years in this field, including a recent focus on children. She was a big part of the 2018 Lesotho VACS, and she's been at the forefront of disseminating the VACS report. So thank you for joining us, May. And finally, I'm delighted that we could get Mr. Mark Mayo, who is a community health volunteer and peer mobilizer at the Kenya Jaramogi Oginga Odinga Teaching and Referral Hospital. And I'm sorry, I'm never quite sure how to pronounce the acronym. I think it's JUTRA. But it is a gender-based violence resource center. He's very passionate about ending violence against children, young people, and women. And I think it's indispensable that we have a male voice in all of these discussions. During the COVID-19 pandemic, Mr. Mayo has been instrumental in actively addressing violence within the community and homes. So thank you, Mark. So to start with some of our questions, first for Dr. Musetti, can you provide us with an overview of the VACS, including their importance, what data they collect, and what survey results are normally used for? I think I touched on some of this in my slides, so I think maybe the focus in terms of importance and how the data is normally used.
Sure, and thank you for providing a good overview of the surveys that allows me to just kind of jump right in. So I think, Andrea, as you noted in your overview, the violence against children surveys are really conducted through the leadership of the local country governments, and it is their engagement that's really essential. In addition to the coordination of the survey planning and implementation through a multi-sector task force that engages all of the relevant sectors who have a role to play in violence prevention, including education and finance and gender and justice, to ensure that there's government ownership of the results, and that the findings are used to guide strong action. And that's really done through a process that we call the data to action process that follows the survey findings being available. The first step is really to raise awareness of the scope of the project in each country, of the scope of the problem in each country, and understand the unique context. So for example, the patterns that we may see in a country like Lesotho, for example, are often different from the patterns in violence that we see in other sub-Saharan African countries, even though they may be in the same region. But we really need to, what we've learned from many years of working with 24 countries around the world is that in order to have true ownership of all of the government sectors, it is to see their data and the voices of their youth reflected in the findings. And so the data to action process really involves engaging a cross-sector response to review the data, understand it, interpret it, and then map, identify priorities for each country. And that really is driven by what the unique patterns we're seeing within each country. And then informing a national action plan. And the national action plan is really the foundational framework used in our data to action process is a technical package called INSPIRE, which was released in 2016 through a partnership between many organizations, including UNICEF, the World Health Organization, CDC, the US State Department, USAID, UNFPA, UN Women, a number of others. INSPIRE is an acronym that stands for implementation enforcement of laws, norms and values, and a number of other strategies. All of those strategies reflect the best available evidence, what we know to date about what works to prevent violence against children, especially in low and middle income country settings. So the data to action process is really about using the VACS data to plug into the INSPIRE framework and identify what are the priorities within this particular country and by sector. You know, education may resonate, what might resonate with education might be slightly different than what might resonate with a social service sector. And so it's really about finding a role to play for each of the relevant ministries and civil society organizations. So I think that kind of broadly answers your question. I'm happy to provide any additional details if there are more questions about that.
Great, thank you, Greta. Speaking of INSPIRE and the multi-sectoral task force, a question for May Mantoa. And I know sometimes we can have some issues with the connectivity in Lesotho, but I think a big question was getting specifics about how the Ministry of Social Development and other stakeholders in Lesotho responded to some of the findings from the VACS.
Good morning, everyone. Thank you very much for having me on the panel. And like it has been said, my name is Mandra Sajagi. I work in the Ministry of Social Development and the Child Protection Department. And I would just want to quickly say, for Lesotho, it really was a big achievement for us to have a VACS report because we have never had a survey of this kind, never. So the report has helped us in so many ways. Coming to the question of how is the report going to help us to inform our programming? I must say that prior to the report, we had programs, though they were not informed by the research that has been done. But with the report now, having this information, it has given us the idea as to the types of violences that are out there. In our case, it the report showed us that there are three major types of violences: the sexual violence, which is the topmost, and the second one being the physical and emotional violence. Child marriage is there also, and it has always been a problem with us, Lesotho. Now, we looked at the action plan that we developed during data to action workshop. The action plan identified the areas where we are saying, this is where we want to start. These are the priorities that have been identified by the report. We realized that with the information that is contained in the report, we know the age groups of the children, we know the sexes, which one is suffering more, the type of violence. And now we are in a position to say that we are ready to bring in the interventions that are appropriate for each type of age group, for each type of violence. We even know now, at least at how much are we looking at, because the previous interventions that we have had, even though they were not specifically for a VACS response, they have informed us as to at least how much we could be looking at. Now, the issues of partnership, we know now that with VACS report, we have identified the partners that we say, these ones are the ones that are going to help us to implement our action plan. I must also mention that the action plan is still in the process of being costed. Therefore, we are not yet ready to implement it fully, but at least we know the priority areas that we should be looking at. Other than the issue of partnership, we also looked at the issues of policy and the frameworks. Our Children's Protection and Welfare Act is not so inclusive in other sections of child protection. The issue of child marriage was not there, and other issues were not clearly defined as criminal offenses against children. But with the report now, we are in the process of amending our act, that it should include child marriage as a criminal offense, and it has to have penalties for those who will commit it against children. Our policy, fortunately, has ended. We are in the process of reviewing it and updating it. And we are saying it's good that it ended before we had the report, because the recommendations that are there in the report will also be reflected again in our police. I think that's what is going to happen with us and the report. Thank you.
Thank you very much for that very comprehensive answer. Now for Mr. Mayo, we have quite a few questions, I think, pertaining to Kenya and to the role of men in the response. I'd love to get a brief overview of your work at the Resource Center, if you're able. Hi, Mark, are you able to? Oh, great, thanks. Hi, Mark, I'm not sure if I can hear you. Are you able to hear us? Perhaps, oh, great, okay. So Mark is going to be sharing some slides. Great, thank you, Mark. So Mark, I'm not sure if you're speaking. I unfortunately can't hear you. I don't know if others can.
No, we can't hear him.
We can't. Okay. Mark, I'm not sure if you want to check your microphone or maybe the connection. Okay, maybe while we work on that, I'll just go to another question back for Greta. There's a lot of questions about how we can use VACS to inform the response to COVID-19 and violence. I think this also ties into another question, whether you're able to do any surveys that are household-based right now during the COVID epidemic. So if you were able to answer some of those questions.
Yeah, happy to. So so to the first question on how can we use VACS data or other data to inform what might be happening, this is truly an unprecedented pandemic, and we have we unfortunately don't have past experiences we can draw directly from to say, what happens when people are forced to stay at home, or when there's even now in many countries where lockdowns have been lifted, the amount of economic devastation is likely a pretty significant driver of violence, even as things are shifting in the pandemic. And we really, what we know is that those who are already vulnerable are likely to have become more vulnerable. So one piece of that is understanding the VACS data that we do have to identify which young people and women and girls are most likely to be experiencing violence. How do we get them services? How do we do that safely without exposing them to greater risk from violence? That often is a real challenge, and one that has limited their ability to access services, as we've seen from some of the presenters around the decreases in calls. But that's really, the VACS can serve as a baseline set of information about what was happening pre-COVID, and then we can assume that whoever is already vulnerable is likely to have become more so. So that's one piece, is in the absence of COVID-specific data, the best we can do is to use the data that we do have to the best extent possible. I'm sorry, I lost track of the second question. It was
well, I think it was about whether
the new surveys. Yeah. So, and we've been working with a coalition of global partners, including WHO and UNICEF and the UN Special Representative for Violence Against Children, and especially with minors who are at home. It is at this time, I think there's a lot of agreement from global partners that the ethics of collecting data either on the phone or through similar methods are highly risky, because it is not possible to ensure privacy and confidentiality. So asking young people to disclose very private experiences may expose them to greater risk, with limited ability to provide them services and provide them supports. So that is really one piece that we've really been cautioning around data collection. The other, in terms of in-person data collection, it really depends widely. We have not initiated new data collection with VACS because of concerns around community transmission. And the first step needs to be to ensure the safety of interviewers and the safety of participants and their families and communities. And so although having good quality data is exceptionally valuable, we want to do that in a way that maintains the safety and health of those individuals who are participating.
Okay, thank you. And just a follow-on question, thinking about that, one of our attendees has commented that there seems to be very high rates of violence in Cameroon right now. And it doesn't seem that there's been a VACS conducted there. So I think the general question is how you actually select countries for these surveys. And I guess a specific question would be whether there's an intention to ever do a survey in Cameroon.
Yeah, so country selection is a bit of a complex process. You know, the surveys require, you know, both funding resources as well as a true government commitment to, you know, to really say we intend to engage in, you know, in this survey, lead the survey, and use the data. You know, we really need that to ensure that early on. The funding piece is a bit complex in that, Andrea, as you mentioned, in sub-Saharan Africa, most of the survey, not all, but most of the surveys have been funded through PEPFAR. Surveys in other regions in Eastern Europe and South and Central America have come from other sources. So it's really a process of local stakeholders identifying funding resources to ensure support, and that, you know, again, in Cameroon, that may come from PEPFAR or other sources. So that's kind of the process. We would absolutely love to work in Cameroon. We've done some work in Francophone West Africa and in Cote d'Ivoire, but I think, you know, as I mentioned earlier, each country has its own story to tell, and it's really important to understand the local context. And you can't just use data from a neighbor country to really understand what's happening in a particular setting.
Thank you very much. It seems that Mark is still having some issues with connecting. I have a question for May Mantoa. Just if you could tell us a little bit about the follow-up that we had for cases that we identified during the VACS in Lesotho. I know in many countries, identifying the resources for providing these services can be a little bit difficult. So it would be great to get your inputs on how you are able to provide support for people revealing often, you know, pretty dire circumstances in terms of violence.
We had support. We had great support from ICAP, because we knew that once they go out there, start talking to the victims, definitely these people are going to relive the trauma, and we had to be prepared for that. So we put together a team of social workers, nurses, and other professional people like counselors who will be working closely now with the ministry, our ministry, and the auxiliary social workers. The auxiliary social workers are those social workers that we have at community level, so that they attend to the victims, because we believed that there will be some very acute cases that will need to be attended to. So we had that support. And many of the cases, according to our Children's Protection and Welfare Act, are statutory cases that are supposed to be dealt with by the government social workers according to the Act. So many of them were referred to the social workers for further management, because if it's a statutory case, definitely it has to end up in the courts of law. So referrals were made as well at that level. And those who needed immediate healthcare services, they were provided with that. It was facilitated. Police stations and health facilities were also involved in the process of giving support to the victims, because the victims were given some transport reimbursement to travel to access these services. Many of our clients are people from the rural areas whereby they have to travel. And another thing that contributed to many of them not eventually going out there and getting support is the issue of traveling long distances and yet not having money to go to the service providers. So the victims were also given reimbursement for their traveling. Yeah, that is the kind of support that we got from ICAP during that time when we were doing the data collection. Approximately around a total of 360 children were identified as in need of social services, and their cases were managed by this team of professionals. Out of that 360, it was only 3 who could not be reached for further management of their cases, but the rest of them were given service. So it was a success for us as a team and as a ministry. Thank you.
Great. Thank you very much, May. And I think there's a lot of lessons learned in terms of trying to sustain those types of programs, especially moving forward for responses to the COVID-19 subsequent violence that we might be seeing. I think perhaps, Mark, as we set up your slides, I'm hoping, oh, he's off again, hoping that we can reach Mark. I do have a number of questions for him, as do others. I did want to ask Catherine if you're still on the line. Great. There's a question both from our audience about how we're addressing self-violence. This is something that you flagged, and it's including self-harm and suicide, and how that's linked to some of the response to violence against others. And then there's another question that hopefully you can respond to in terms of how we're dealing with violence in homeless people, and what you think will happen when no longer support for housing victims of violence.
Thank you for those questions, and they are both supremely important, and they are integrated into our analyses and our actions. So let me address the self-inflicted injury and suicide risk topic first. I will share that in the health department's outreach and attention to the mental health consequences of the pandemic and messaging therein and communications around supports. In that outreach work is embedded without a full clarity of the data pathway therein, but with a supreme understanding of the comorbidities that reside there. There is domestic violence support resource and prevention messaging in the suicide prevention messaging that is COVID situated. My team analytically is examining the co-occurrence and the sequential pathway of risk on those two outcomes, but we have a very limited data to stand on. I am comfortable saying the following: it is looking like that there is a subtype of suicide deaths when there is intimate partner violence history on board in their circumstance proximal to the death. There are some other characteristics of those suicides that look a bit different from the suicides that do not have that life circumstance on board. My data sourcing there is the National Violent Death Reporting System. Regarding the outreach to the homeless, we have a indirect reach with regard to that, and it's twofold at this moment, but I'm happy to delve deeper with some sister agency work, because I may not have the most comprehensive answer here. But through the task force work, the city collaborative work on domestic violence writ large, we have been pushing the service messaging out to other service providers and advocates and community-based organizations. So those who are working directly with the homeless are also in receipt of the domestic violence messaging. And secondly, I am aware, and here I am reaching a bit beyond my wheelhouse, but I'm aware that the Mayor's Office to End Domestic and Gender-Based Violence has outreach teams that are working a bit on the ground and also remotely in areas of high need across a range of social issues. And in those outreach activities, they're meeting people where they are, including not being sheltered, and delivering messages about how to be safe from current or historic violence in the home or through intimate relations. That resource I flashed at the end of my presentation, the multilingual resource, is also disseminatable, if you will, in palm card form. And I am not certain where we are at as a city in full execution of that, but I know it's in the works.
Great, thank you. We are approaching the end of the session. I apologize that we were unable to hear from Mark. Hopefully we can get his slides, and we'll post them as part of the webinar. And if anyone has questions for him, including there's a question about the role of machismo in violence, and other questions about Kenya and accessing care there. So hopefully we can share his contact information with anyone who would like to ask him further questions about the work in Kenya. I did have one final question, and this is for the panelists in general, thinking just the note from Dr. Diop, who unfortunately had to drop off, about the role of armed services in preventing violence or responding to violence. And getting inputs. Certainly we've had issues around police and violence in the United States, and I think this has been something that's arisen in multiple settings. So to get the experience, either Memantoa, Catherine, or Greta, on the involvement of police, and if there are any circumstances where you feel that it's unsafe to involve armed services versus others, what are the criteria for involving them?
This is Greta. Perhaps I can get started. You know, I think this is a very sensitive and complex issue. And so I would say before starting with criteria, it is absolutely essential to ensure that there is good quality training for police and other justice professionals for any involvement at any stage, right? From, you know, someone first experiencing violence and needing to report a case, all the way through the criminal justice experience, to ensure that those efforts are victim focused and supportive of victims. And you know, police have a really important role to play in ensuring the safety of communities, but oftentimes their background and training is not very focused on gender-based violence and awareness of these issues and norms. And so I think a really strong partnership with police is needed to ensure that that when their involvement is warranted, that it is done sensitively in a supportive way. And so I think that's really kind of the most important place to start, is to ensure that, and oftentimes that engagement, you know, through a lot of the GBV services that have been provided in a lot of these countries, especially through, you know, our experience with the PEPFAR services, for example, really emphasizes the importance of one-stop shops for victims to reach health facilities first, and then that can be a really valuable entry point to ensure that the services are provided, and then the police are engaged when it is safe to do so and in a safe manner.
And this is Catherine adding to that. In New York City, we're very much promoting and positioning healthcare as a place to start for safety and service, understanding, and even referral. And we are forever reinforcing, and this has been part of our messaging for years, that it is survivor determination about what service to seek, when, where, and how. And one of the best ways to elevate that choice is to make sure all friends, family, neighbors, coworkers, other service providers, community-based and otherwise, know the full range of resources out there, knowing that they are complements and supplements to each other, not that there's a hierarchy of response, or that there is a single place one must start.
Okay, thank you, Catherine. We're exceeding our time, so I'll wrap up. I just wanted to say a huge thank you to our speakers and panelists. Really insightful discussion. Also, thank you to the audience. Really great questions. As I mentioned, unfortunately, because we missed Mark, we will hopefully be able to include his presentation as well. So thank you, everyone, and I hope everyone has a great day and evening.